Hey, it's Dr. Tydell. I got way behind on the respiratory system, and so I'm going to record these videos. Frankly, I'm hoping that without a live audience, I might be a little bit less likely to go off on a tangent. Let's see if this works. So we've been talking about respiration, and there's a lot we've learned already. But one of the things that we just started talking about is what actually regulates your respiratory rate, whether you are healthy or whether you have got a patient in the hospital who is not healthy. And we've learned that the respiratory system does not use oxygen as it does not try to measure oxygen levels in order to decide when it's time for you to take another breath. And that means a couple of things. It means when you are asleep at night, the reason that you inhale and exhale has nothing to do with oxygen. The second thing is that what is regulating respiratory rate is primarily going to be the pH of the plasma, which affects the pH of the cerebrospinal fluid, and CO2 levels, which are directly measured, but also change the pH of the plasma and change the pH of the cerebrospinal fluid. So it's pH and CO2 levels. So let's go back to the first concept. When you're asleep at night, your body does not know how much oxygen is in your blood. And so you will be quietly, comfortably inhaling and exhaling as long as CO2 and pH levels remain within normal limits. This is the reason why people will die of carbon monoxide poisoning without ever waking up. Carbon monoxide is a toxic gas. It binds to hemoglobin with a higher affinity than oxygen does. And so when there's carbon monoxide in the atmosphere, it displaces the oxygen on your hemoglobin. And you are running out of oxygen in those situations. But you don't wake up, you don't start breathing faster, you don't get that, oh my God, I'm dying sensation. Why? Because breathing in and out in the presence of carbon monoxide does not change your CO2 levels or the pH levels of your blood. And that is why people poisoned with carbon monoxide will just quietly fade away and die for lack of oxygen. Now, the flip side of this a little bit is that any condition that changes the pH of your body will change your respiratory rate. And one of the things that we talked about last term was that uncontrolled sugar diabetes mellitus, will lead to an acidosis. That kind of acidosis is called a metabolic acidosis because it's an acidosis that is not related to the respiratory system. There really are two kinds of acidosis. One of them is going to be an acidosis that's caused by some compromise of breathing, and then everything else. Everything else that causes an acidosis is termed metabolic. Metabolic acidosis can be a poisoning, like aspirin poisoning. Metabolic acidosis can be caused by like diabetic ketoacidosis. Okay? Any kind of an acidosis is going to change the respiratory rate. The patients will breathe more deeply, and the patients will breathe faster. If you ever in your entire career see a patient who is breathing very deeply or breathing fast while they are unconscious, one of the first things you should consider is uncontrolled sugar diabetes. That probably is the most common cause of an unconscious patient that is breathing deeply or rapidly. Okay. So acid-base regulation. Now, alkalosis, and remember, acidosis does not mean that the pH of the blood is acid. It means that the pH of the blood is anything less than 7.35, right? So 7.25, technically not acid, but still, if it's at your blood, acidosis, right? So alkalosis is the opposite. It would be a blood pH greater than 7.45. And respiratory and metabolic alkaloses are actually much less common. Alkalosis in humans is a much less common health problem. A metabolic alkalosis can be because of a toxicity. That's probably the most common cause. Or a respiratory alkalosis, the most common cause is hyperventilation. Okay? Hyperventilation, we usually think of as people that are freaked out and they're breathing too fast. Yes, that would be a respiratory alkalosis. However, if you are manually controlling your patient's breathing by like particularly in an emergency situation, you'll be bagging the patient. And it is just our nature that more breathing must be better breathing. So it is very common if you get a patient in that's being bagged by an EMT from an ambulance, if they are new at their job, or if it's you, that you might be breathing too fast for your unconscious patient. And you might think, well, what's the harm? More breathing better. Well, the harm is to create a respiratory alkalosis. And just as a patient that is hyperventilating will pass out from the respiratory alkalosis, if you are overventilating a patient, or if that well-meaning EMT or newbie on the ward is overventilating a patient, it also will cause a change in vascular constriction to the brain that will cause the patient to pass out. Okay, so be careful when you're manually ventilating a patient because too much is also damaging. Right now, I don't want to dwell on this too much. This, by the way, is what ends up going, this is called an acid-base nomogram. And it particularly when you're doing your anesthesia rotation, this is the kind of thing that you need to learn. But I don't need you to memorize this. I do want you to know something though, okay? That in the acute situation, an acidosis or an alkalosis is very linear and understandable. However, when either an acidosis or an alkalosis is chronic, has been going on for a while, then the parameters that are measured in a blood test and the response of your patient is less anticipated. Okay. Now we're doing the respiratory tract, so we are only going to be focusing on respiratory. Okay. So, oops, and blue. So, boom. We're not going to be talking about metabolic. Okay. I want us just to focus on this. When a patient has got a respiratory acidosis like COVID-19, then immediately what's going to happen is the pH of their blood is going to go down and their CO2 levels will go up and their bicarbonate levels will go up, okay? Now, this is going to be experienced by particularly by their central chemoreceptors as requiring faster ventilation, right? Okay. Now, remember I told you that we have all kinds of COVID-19 patients that come into the hospital with very low blood oxygen, only 70%, and they are not breathing too fast. And they say, yeah, it's hard to breathe, but why is that going on? Okay. That is going on because their body is compensating. So let's have a look at this darn nomogram. And I always find the nomogram very intimidating, but you guys are smarter than me, so you won't have a problem. Let's look at acute respiratory acidosis. You'll notice here that the arterial blood pH is going to go down. We'll get back to that in a second. And their bicarbonate levels are actually going to stay in the typical range. Okay. Now, what is going to happen when it's chronic, when your patients had COVID-19 for a while and they've had a chronic respiratory acidosis, their pH levels are not as low. They actually can be very close to normal, okay? But what is happening is their bicarbonate is compensating. And so with really chronic hypoventilation by a patient like with COVID-19 or chronic respiratory diseases, their blood oxygen levels can be low, but over time, their acid-base buffer system will compensate, which will decrease their sensation that they are hypoventilating. And since the system that is measuring oxygen is not very useful, then they don't know that they are very hypoxic while they're sitting there. I was going to say something about arterial blood gas. When we are checking blood pH, we never do it with a venous sample because many things will change the pH of a venous sample. If you just run a 100-yard dash and I take some of your venous blood, it's going to be acidotic. So we don't evaluate acid base or bicarbonate using venous blood. It's always arterial blood. Now, this is important. We draw venous blood all the time. You draw some blood, you hold it off like this, 1, 2, 3, 4, 5. You put a little Band-Aid on it, all's good, okay? That's because veins have got very, very low blood pressure in them, like right around 5 millimeters of mercury. So they are unlikely to bleed because you get a platelet plug that quickly, okay? The arteries have got high pressure inside of them. So you generally will use a smaller needle to draw an arterial blood sample. And it is very important for you to actively compress that artery for a period of time after acquiring an arterial blood sample, or you will get a really significant hematoma, big blood pocket after doing that, right? Okay, we're going to go back to this at the beginning of my next lecture.